And we're fortunate to have our panel today. I want to thank all of them for their time. We've had a couple of planning meetings, but their time and effort in going through all of this. And in presenting order, Mandy Lamb is the program manager, education and technology platforms for the Wetzman Institute and the Community Health Center. And Jeff Howard is the CFO for Cherokee Health. Carla Horton, RN and certified diabetes educator, is a registered nurse with Tri-Area Community Health. Serene Garcia is Director of Special Programs with Finger Lakes Community Health. And Kim Swartz is the CEO, and Corey Erhardt is the Director of Population Health with Roanoke Cowan Community Health Center. So again, we are fortunate to have these folks, and I'm certain they'll bring a unique perspective on how they're using telehealth in their community health center. So, Mandy?
Thanks, everyone. And I'm going to try to hold the microphone up. But if you can't hear me, just raise your hand or shout out. I'm going to try to remember to hold this up. No? Green. Does this work?
There you go.
Okay, great. All right, so I am Mandy, and I'm coming to you from Connecticut at the Community Health Center. So a little bit about sort of the Community Health Center before we get into our work around telehealth, but also with the work we've been doing with telehealth with other community health centers across the country. So we are a federally qualified health center in Connecticut. We're the largest in Connecticut. We have 15 main sites. That's brick and mortar sites, as you can see from this map, but we also have 204 access points across the state of Connecticut, mainly in school-based health center sites, but we are in homeless shelters, and we do have a large mobile dental program. Again, we have a large staff, and we started in the 1970s. Our CEO is still our CEO today. He opened, a one-room clinic back in 1972 with him and his college friends, and we're still here today. So going from one small clinic to 200 locations across the state of Connecticut. And our sort of three foundational pillars for the Community Health Center and the work that we do are clinical excellence, research and development, and then training the next generation. And so that brings me to sort of describing what is the Wetzman Institute. So the Wetzman Institute is just another branch of our Community Health Center. So it's just another department. It was founded in the early 2000s. We began doing more research and innovation work, both within our clinic, but with other health centers that we've partnered with across the country. And here's a picture of our building here, but we have a brand new building that just opened 2 months ago, and that is our knowledge and technology building, just in terms of the growth that we've seen over the past decade since we started formally doing work under the Wetzman Institute. And the Wetzman Institute is named after a pharmacist who was one of the first providers in our clinic in 1972. He was the first one to sort of step up and say, hey, I like what you guys are doing. I'm going to take a risk and start doing work with you. And he tragically died in a car accident in the early 2000s. And so in his honor, we named our Research and Innovation Center after him. Again, one of the founding principles of the Community Health Center is this idea of innovation. So we were early adopters of two telehealth interventions, and they're not probably what you're traditionally thinking of when you think of telehealth. So it's not the synchronous session between a patient and a provider. We use two different telehealth technologies, and one is e-consults, which are asynchronous consultations, and I'll go over what those are. But we also were early adopters of the Project Echo model, and sort of my role at the Community Health Center has been really to see the growth of our Project Echo program. And then, again, we do some traditional telehealth, but again, our biggest portion of telehealth within our own clinics has been through the use of these two platforms. Again, a lot of you might know about Project Echo, which sort of has mushroomed across the country and the globe. And some of you have probably either participated in a Project Echo session or run Project Echo. But as I said, the Weizmann Institute was an early adopter of the Project Echo model, which was founded by Dr. Sanjeev Arora out at UNM. His mission was to sort of, he's a hepatologist, and he was the only one seeing Medicaid patients in New Mexico, and so the wait line was very long to his clinic, and so he really wanted to train primary care providers to treat this patient population within primary care. So when we heard about this model, our clinical leadership went out to New Mexico and was trained. Again, we were one of the first adopters of the Project Echo model, and what was unique about our situation is usually those who are running Project Echo are teaching hospitals or universities. Unfortunately, at that time in the state of Connecticut, we couldn't get any of the universities to sort of get on board and sort of take their specialists and do a Project Echo in the state of Connecticut. So our leadership really was invested of, why don't we just do this ourselves? So what we did, we started in 2012 with our hepatitis C HIV Project Echo, and then quickly launched our buprenorphine echo, which is now our medication-assisted treatment echo. But really what we wanted to do with Project Echo is that we have 15 sites, but we had only one provider who was X-waivered in buprenorphine, and only 2 providers who really had a solid knowledge of how to treat patients with hep C HIV. So what we wanted to do is we wanted to retain our patient population within our clinic, because a lot of them were getting lost to care. And even though we're not in a rural setting, a lot of the populations that we're treating just don't have access to specialty care. Either it's long wait times, or again, 70% of our patient population is Medicaid eligible, and they're just, the specialists won't see them. So we sort of wanted to take our own primary care providers and give them a support network to sort of treat patients with these conditions. And as you see here, we started off with buprenorphine and hep C HIV, but we have a pain clinic that we've been running for many years. We have a complex integrated pediatric, and before that we had pediatric behavioral health, because we are from the state of Connecticut, and when Sandy Hook happened, we have a lot of school-based health center providers who sort of needed that support of, how do we, address sort of the behavioral health needs within our clinic, and how, as school-based health center providers, can we support our community right now. And again, we just launched a community health worker program, which again is for community health workers. We also have a complex care management which is just for our nurses. So we've seen sort of a move to value-based care within our agency. We have several value-based care contracts, and as we move to that sort of model of funding, we really value the role that nurses play and how they can sort of manage our patients. So we have an echo just for them, and it's a bi-weekly session that they can come together and talk as a group about their most complex patients. So again, that's sort of how we started to do Project Echo, is really because of it addressed a need within our own clinics. But we don't sort of work in a silo. We talk with other health centers across the country. We collaborate with them, and so over the course of 7 years, we've held, as you can see, 864 echo sessions, but we've had a large community of providers who have joined us or in various echo clinics. So we've served, I think, over 1,200 providers nationally in the past 7 years. And so, because I only have 15 minutes, I wanted to give you just a snapshot of what has Project Echo sort of done for our providers. And we can say it supported them, but we've done some research in terms of how did Project Echo help us scale our resources for addressing the opioid epidemic within our own clinics. So one of them, this is just a snapshot of some research that we did in terms of if you participated in our Project Echo sessions, we saw providers who started out with echo, they might have only had one patient on their panel who was being prescribed buprenorphine. Again, when we go to roll out these types of programs in our clinic, our providers were very hesitant about, prescribing. They didn't feel supported. They may have gotten their X waivered, but again, that's just one step in getting them comfortable and sort of prescribing buprenorphine or other MAT within the clinic. So they might start with just one patient on their panel, but over time, the average is 33 patients on their panel. And what's not up here is that we have high retention rates in terms of providers who join our ECHO at our community health center. We're able to sort of maintain patients and keep them in treatment. And again, the more they participate, the more they submit cases, the more they attend sessions, the sort of better they are in terms of keeping patients on their panel and feeling supported. One other quick thing of how we use Project ECHO in terms of sort of our guiding principles. As I said previously, we're really focused on training the next generation. So we actually host nurse practitioner residency programs in our own clinic, but we also host them in 7 other organizations across the country. And again, this is partnerships we have with other FQHCs. All of the nurse practitioner residents who participate in this year-long program have to attend our Project ECHO pain sessions because we just see that as such a valuable intervention at a very early stage for clinicians who are new to practice. And so we've had them join pain, and starting next year, they will be also joining our MAT program as well. And just in terms of briefly, what are residents saying that they're doing different from joining our Project ECHO Pain series? Again, a lot of them are just reporting back, and we've also done research on terms of how much they're referring to behavioral health. Because as our Project ECHO Pain faculty and other experts that we work with will tell you, a lot of pain issues are really trauma issues that haven't been identified and haven't been treated. So again, we see a lot more referrals to behavioral health. We see a lot of our residents who are saying that they're now working with their behavioral health colleagues in a different way. So that's just one way Project ECHO and this telehealth intervention has sort of supported our providers in providing better treatment for our pain patients. And so then just briefly in terms of, we've been doing Project ECHO for several years now with FQHCs across the country. And really the focus of ECHO is really expanding providers' clinical knowledge in certain clinical areas. But what we haven't been doing and what we hear more of is sort of this need for a practice transformation. So as much as you prepare your providers to treat these conditions, there's still a need for how do you implement this in your own organization. So we have been doing quality improvement for several years now at our institution, and we're now sort of launching a more learning collaborative type of community, and our first one was launched for medication-assisted treatment. So we work with partner health organizations across the country in terms of how do you build policies, procedures, how do you implement some of the grants that you've been received. So I think there's just a lot that clinics want to know of how do we, beyond just preparing our providers, how do we get the clinics up to their level in terms of really trying to unroll some of these initiatives. So that sort of is the broad overview of Project ECHO, what we've been doing, and sort of the Learning Academy, which goes along with our Project ECHO model. The second big telehealth intervention that we've been using is e-consults, which are an asynchronous consultation with a specialist. So how it works, and I know there's different e-consult models out there, and you might be familiar with them. For us, we have a referral team on the back end that sort of works on the workflow within our own organization, so it's no extra burden to any of our providers. The more clicks you add for our providers, the less likely they are to sort of submit an e-consult. So we really work to embed e-consults within our referral process. And within 2 business days, they get a response back from a specialist. So we actually have a large, over time, we've built a large network of specialists that we're connected with across the country who really sort of bought into this model of telehealth, that we can quickly connect our primary care providers to one of these specialists. And the reason we invested in this type of telehealth intervention is because we noticed that 35% of our primary care patients are referred to specialists on an annual basis. And then 45% do not actually require a face-to-face visit. And so we really have sort of taken this research to say, you know, how do we not lose our patients to care? Because again, a lot of the times, you know, they're getting lost because the specialist won't take their insurance, or again, they don't have the transportation to actually get to the specialist. And so we actually did a study when we first launched sort of our first e-consult pilot, and it was on dermatology. So as you can see here, before we implemented e-consults, we had 1,200 referrals to dermatology in 1 year. And actually, if you follow that chart down, only 139 actually saw the dermatologist. Either they missed appointments or they did not receive an appointment because transportation issues, or the specialist did not take their insurance. And then so we did this e-consult pilot for dermatology, and you'll see here that with e-consults, there's a majority of them, 44%, did not actually require a face-to-face visit. So the primary care providers were able to treat that patient within primary care with the support of this consultation by a dermatologist. And then you can see here with the e-consult intervention, you can see that for those who did need face-to-face, there was a higher number who actually got the care they needed. Again, that's sort of the first pilot we ran. So after that, we sort of expanded our specialty areas and sort of began also working with other FQHCs across the country who are interested in this type of model. And we recently we had some research that just came out in Health Affairs about sort of the cost savings analysis of e-consults and how it, in terms of just from the state level and from Medicaid, the reduction in cost if you include an e-consult intervention into the into the patient's treatment plan. So I won't go into that today, but it is available, and I'd be happy to discuss it with anyone after this session. In addition, we also have several publications about our Project ECHO telehealth intervention and sort of both the clinical outcomes from sort of using Project ECHO for our primary care providers. So again, I can answer any questions following the panel, but that's all I have for today.
My name is Jeff Howard. I'm the Chief Financial Officer at Cherokee Health Systems. And if you've heard of Cherokee Health Systems, I guarantee it's not because of anything financial. It's because of behavioral health integration. We've got a lot of staff involved in that. But telehealth is one of the areas that I've been interested in and I've been involved in with Cherokee Health Systems, so I'm excited to be able to talk about what we're doing in that realm. So Cherokee Health Systems, we are a mission-minded organization. We're a community health center, a federally qualified health center. We actually started as a community mental health center. And so in our mission is blending behavioral health and primary care. So that's what we've been doing for a lot of years. That's really who we are. If you look at our service area, we are in Tennessee, primarily in East Tennessee. We have recently expanded into West Tennessee. We're getting ready to open a second office in West. And the Chattanooga area, kind of down in the southern part, that's another newer area for us. But this is the area we started, kind of in the East Tennessee area, Knoxville, that area. We have a lot of sites, a lot of staff. We have 723 employees. If you look at our provider staff, and sorry, I didn't fix this slide, when things shrink, it kind of throws everything off. Psychologists, we have a lot of psychologists. Primary care physicians, 22. Mid-levels, we have 58. But the big thing up there is roughly 17,000 new patients per year and almost 73,000 patients served last fiscal year. That's nearly 400,000 services. We are completely outpatient, with the exception of a small crisis stabilization unit for behavioral health patients. But outpatient is really what we do. Our emphases, you notice telehealth is up there. Since we started doing this back in the kind of the early to mid-90s, we started looking at telehealth. And we realized it was something that the patients needed. We had providers who would not go out to some rural areas. We had patients who would not come in from the rural areas to the more urban areas. And so we had to find a way to connect them. But the way we look at things is blending behavioral health and primary care is major. We go where the need is there. So where the grass is browner, that's kind of one of our sayings, is we go where the grass is browner, because we do follow the need. Outreach and care coordination are major for us. Training, value-based contracting, healthcare analytics. We see value in all of these things. But if you think of telehealth, this was an article from 1924. People were actually thinking about telehealth in 1924. This was the radio doctor from the Radio News magazine. Dr. Greg Perry, who could not be with us today, is our director of psychiatry and our director of telehealth services. He brought this in, and he likes to look back at, this has been around for a while. The idea has been there. But when we started doing this, these were some of the things that were going on in the world. If you think of the late 90s, I got a kick out of this one. From back in 1990-something, Donald Trump says, "I want to be prez." And one of the things, the reason I throw this one in, does anybody know who that is? Max Headroom? That's what Dr. Perry looked like in the early days. If you remember what Max Headroom was like, choppy video image, choppy sound. Technology has improved greatly. We actually started with a 56K line, telephone line, plain old telephone line. Has anybody in here tried video on a 56K telephone line? It did not work for clinical applications. But then a company came out with this neat device that bonded two of those phone lines, and you could actually get 128K out of, or 128K, I believe, is what they advertised. But you could get that out of the basic phone line. And then ISDN, and then T1 lines. And so we've gone through a lot of experiences with telehealth. But some of the ways that we use it now are in primary care. Every day we have primary care providers seeing patients via telehealth. Most of those are in schools, but even in our bricks and mortar sites, we have primary care providers seeing patients via telehealth. Specialty mental health, that's the area we started in. Psychiatry was the biggest need that we had, and so that's the first application, the first clinical application that we had. Now we do behavioral health consultant consults, pharmacy, discharge aftercare, planning, mobile crisis, mental health, hospital admissions. You can see all the different applications. Really, it's a technological tool that helps us connect the patients with the providers for whatever the need is. Just a few pictures, and I'll talk about some of the history as we go through this. This is Dr. Perry. He couldn't be here with us, but that's the back of his head. In the early days, he used to be a production manager for a pretty famous person from Tennessee, Dolly Parton. He was actually her music director, traveled with them before he went to medical school. So his thoughts were, you need to make this a good quality image. It needs to look like what people are used to seeing on TV. And so lighting was a big deal. This was the first cart that had the specialized lighting. He picked up some lights from Lowe's and some kind of diffuser panels, PVC pipe, and that was his lighting studio. And it was great. I mean, if you looked at the image, you can barely see him down here, but it's good lighting. In the early days, the cameras didn't really pick up the image that well, didn't handle lighting that well. These were older Polycom units. The technology's improved greatly now, so we don't need as much specialized lighting, but that's still an important thing for him. You don't want the technology to distract from the patient. And so if you look at what the patient sees, very good image. If you look at what the provider sees, it may be a messy room, but he can focus on the patient. The other thing that I'll point out here, this was a psychiatry session, and this is his nurse. We also always have somebody in the room with the patient because there's some things that can't be transmitted via video. Smell. If a person comes in intoxicated, you may or may not be able to tell from the video image, but if the nurse says something like, well, how's the weather up there in Morristown? If they talk about weather, that means this person really smells intoxicated. So they have some codes because, again, not everything is transmitted. This is one of the newer setups. Again, this is the nurse, the same nurse, Joy, with a patient, seeing the provider. So again, the image is clear for the patient, and then the provider is in a different one of our offices. We also have setups where the provider is based at home, or I'll show you a few others where the provider could be located. This is one of the school-based studios. We have a central studio for telehealth, and this nurse practitioner beams into 25-plus schools every day. It could be any school. It's just a matter of changing the channel. But this is a neat program that we are involved in with Sevier County Schools, again, the home of Dolly Parton. But they came to us several years ago, and they wanted us to open clinics in their schools because they had read where they were getting a lot of reductions in funding because of their attendance. And if kids are sick or have to go to the doctor, they have to get out of school, get the appointment, they're out the next day to go to the doctor. So in this scenario, if the clinic was in the school, the kid could come in, could go see the doc. If it's nothing contagious, they could stay at school. They could come back the next day. The parent wouldn't have to get off work to take the kid to the doctor. And so since we could not afford to put nurse practitioners in every school, we proposed the video solution for them. And they've gotten some awards for that. And it really has decreased attendance, or decreased, absences, thank you. Some of the specialized equipment here, the camera that can look in the ear, the stethoscope, yes. Finance guys don't know all this stuff. But again, lighting is important. The kids need to be able to see the provider clearly. This is one of the primary care setups where the provider is actually in another state. She beams in from her home in Lexington, Kentucky, and sees patients in our Morristown, Tennessee office. This is actually the office where my wife goes, and the primary care doc that my wife sees by video. So I'm very familiar with patient feedback from this scenario. So if anything is out of the ordinary, I hear about it. So, which is a good thing. But the other neat thing, if you think about a kid going to the doctor, if they could see inside their ear, things make a lot more sense. Instead of just saying your ear's infected, you could say, see how it's a little red here? And if we move over here, see, this is what makes your ear work. I mean, you can do a lot of education, and the kid is interested, and they really understand more what's going on if they can actually see. That's not something you can do in a face-to-face visit. Usually the devices that you use to look inside the ear are not something that you can then project for the kid to see. Another specialized camera allows you to look very closely at the skin. Again, in some of these cases, it may actually be easier to see it on the screen than see it through a device. or looking there just in person. Very high quality images. You could take a snapshot, save it in the chart. Just a lot of benefits from the technology. Pharmacy is another one of the applications that we are doing. And this one took some convincing with the state because this was not a valid form of dispensing medication in Tennessee. And so our director of pharmacy went to the state board and asked for approval for these types of video consults for dispensing meds. We had to start with uninsured first, but they've now allowed us to expand that to any payer. But in this scenario, the pharmacist is at our central location. We have remote dispensing sites staffed with a pharmacy tech, but then the pharmacist is available by video to do the actual consultation and dispensing. We have mobile workers, either care coordinators, case managers, or mobile crisis workers. Again, with laptops and video, you can beam into anyone. We've got a centralized crisis intake unit where our crisis workers can operate. And they're connected with all the area hospitals for the mobile crisis team. So if they need to do a consult, they can do it without driving out there. So that's just a few of the ways that we're using the technology. If you look at the volume, we're looking at calendar year 2018. And so with our behavioral health therapy and behavioral health consultant visits, that one's not used as much, but 91 patients received care, and that was 180 visits. Psychiatry is by far our most utilized service, but 3,600 patients access psychiatry by video. 10,261 visits. Primary care, 1,600 patients last year, 2,700 visits. And then other things like care coordination, 207 visits. So overall, over 13,000 visits with telehealth. Some of the challenges in the beginning, the equipment is expensive, especially if you have to get a cart that's a medical cart. A lot of times we'll buy the carts that are not medical because they're carts. I mean, they hold the TV just as easy as anything else. Complicated network infrastructure, that was our biggest hurdle, just getting adequate bandwidth at the sites where we needed it. Rural areas, it was more costly. So we've had to take advantage of the USDA arrangements, rural utility service. We try to get as much funding as we can to support that bandwidth. Dedicated office space for telemedicine setup. Again, this is getting easier. We don't need all the specialized lights now. So it makes it easier to roll a cart from room to room or just use laptops. Provider buy-in. This one is kind of, it can go either way. Some providers love it. They think this is just the greatest thing, that they can see kids in this way or see adults in this way. Others are scared to death of the technology. And it's really, you just have to talk to the providers and see their willingness to accept this. We have some excellent providers that will not use this technology. We have other excellent providers that will. So those are the ones that we get involved in this. And then training on workflow. It does change the workflow. You can only have one exam room tied up at a time, really, with the patient and the provider. And so you have to either move people or move equipment. A lot of times it's easier to move the people than to move the equipment between offices. Currently, we do use more inexpensive equipment, webcams, iPads, iPhones. And it's interesting, some of the iPads that we use carts that are more expensive than for a TV. Just because it's a small device, it's easy to get a small cart that will turn over, and you don't want to smash your iPad. But you do have to have the protection for the iPad and a good quality cart. We're using more of the cloud-based video services. Zoom, we use that quite a bit now. Broadband internet is a lot more available. Dedicated office space no longer required. Providers are buying into it much more, especially as they have cell phones, mobile phones. Everybody's really used to seeing small screens now. So it's not like we have to make a production that's the same quality as a news broadcast. We just have to do something similar to YouTube. And kids and adults will buy into it. And now telemedicine visits are really part of the everyday workflow. We have people now saying, well, can't we just do that by video? And, you know, for people that are more involved on the technical side, that's a neat thing when you start hearing providers say, hey, we could do this by video. We actually had one of our providers that recommended that we get an app so that we could work with our buprenorphine patients, the MAT patients. And so now we've got an app, I think it rolled out just a week or two ago, where we can give it to our patients. They can consult with our providers real time if we have the providers set up. Right now there's just certain schedules where providers are available, but it's built on similar to the Uber technology where you log in. Any provider that's logged into the system could then accept that call, similar to Teledoc. If any of you use Teledoc, that's a neat tool. We use that for our staff, for our health plan. One of the areas that really bugs me is in the whole financing side of telehealth. And since this is community health centers, FQHCs are not authorized to serve as a distant site for telehealth. That drives me crazy. Why can we not be a distant site? So that's really causing problems with Medicare, because we can't bill our Medicare visits. The location of the practitioner, let's see. So yeah, the location of the practitioner, that can't be an FQHC. We can't bill for these services, but we can be a site where the patient is located. So if we had somebody else beaming in to our office, they could bill for the service. But if we have somebody beaming into our own office, we can't bill for it. So it doesn't really make sense. We're really hoping that will change soon. Some of the lessons we've learned, our CEO says this a lot, patients always point the way. And so if it's a need that our patients have, we need to find a way to meet it. If video is a way to do that, then so be it. Good technology is essential. You can't do this with lousy technology. Management support is key. Billing can be difficult, but usually possible. Advocating for policy change is important, and keep it simple. You know, policy change, we work through our primary care association quite a bit to help Tennessee change their rules to meet our needs. So use your primary care association. That really helps. So that is Cherokee.
Before they see the provider, whether it be Dr. Stanton or myself, we'll get the necessary vital signs, of the patient. Another great thing that we have at Tri-Area is we have digital retinopathy, and lots of times we'll do these tests before they even see Dr. Stanton, so they can have the test results sometimes that day, which is great for the patient because they don't have to make another visit. It's all done right there. Same visit. Your case manager is a key person here too. We share an office. We both know each other's responsibilities, which is fantastic because when she's not there, I do paperwork and get Dr. Stanton set up, and vice versa. She does the same for me. So the more people that you can get involved in your clinic, the better, because that way people aren't afraid of this technology. They're not afraid to touch these machines and plug them up. And, you know, there are going to be things that are going to happen. You know, you're going to have your little setbacks, but you work through it, and it really does work well. Here's Dr. Stanton from UVA, and he's seeing a patient, and this is one of our units. As you can see, this room here where we've got this patient, behind we have those blinds shut, which is a great thing because lots of times if you have the blinds open, it can cause a lot of distortion on the picture. So you have to have your room set up so that everything's in check. This is one of our larger conference rooms, which is wonderful. It has a very different setup. This TV that's on the wall, we can actually bring up, you know, our ECW on that. And Dr. Stanton is seeing a patient, and the nurse is there seated at the table, and she can bring up that patient's chart because lots of times he's like, okay, I want to order this test, and I want you to do this today while the patient's here, and blah, blah, blah. And you can just put the orders in right then. As soon as they leave that room, they're headed to the lab to get their lab test, and then they're headed to get a digital retinopathy scan. So, and then if he decides he wants a patient to be seen by one of your providers, one of our providers, we can also set that up too. So that patient is seeing all these providers in one day, which is wonderful. This is our IT person, Tom Barnard. You really want to get to know your IT people because they can get you out of some jams. All you have to do is pick the phone up, call them, and say, hey, look, you know, I've set this up. I've done everything you've told me, and it's not doing anything. What am I going to do, you know? And most of the time, it's just something very simple. And you just fix it and go on. Here are our specialties. We have 24 different specialties that we can see through University of Virginia Telehealth, and it's really worked out wonderful. Of course, I'm more partial to endocrinology because of being a CDE. I'm interested in the diabetes aspect of it. But when we first started with telehealth, UVA provided diabetes classes for our patients. And so that's how we got started with Dr. Stanton as well. He came to us 3 years ago and started seeing patients, and it's just been a great relationship ever since. What works? Communication utmost. Just get everybody on board. Get as many people trained as you can. I mean, don't leave anybody out. We want everybody to know how the units work, how the room setup works. Cost containment, I touched on that a little bit earlier as far as patients being seen, different visits, multiple visits while they're there. Doubling up on appointments. Collaboration with other UVA specialists is a plus. And we just have started using more of the patient home monitoring. Dr. Stanton, he loves continuous glucose monitors, and we've really jumped on board with those. So he's able to get those patients' blood sugar readings before he sees them. He can check up on them, and he loves that. So that works really well too. The most important thing, and especially in a rural area like we are, is empowering the patient and making it fun for them and getting them not to be so nervous about it, you know. Seeing a television doctor is just not what some of these little people want to do. And most of the people that I work with are the elderly, and they are really not going to do that. So when one person sees a doctor on TV, like I said, the news travels fast through Laurel Fork, and it's okay, you know. This is Ricky. He's my Dotson, and I thought maybe if y'all were getting a little bit bored, I'd throw him in there. But this was Christmas, and Ricky looks like he's got a lot on his shoulders, and that's what I feel like sometimes people with telehealth, when they first start into it, feel like. They think it's a lot, you know, the technology's tough. The doctors, they don't want to do it. We still have several, too, that they're starting to come on board, but some of them will not, you know, they don't want any part of it, but it's getting better. Our challenges have been lack of infrastructure in a rural area. We have this one unit that we use, and it's so funny. Dr. Santon, he'll say, all right, are we using that unit that cuts out at 15 minutes? And I'm like, yeah, that's it. So remember, so we always tell the patient, and we haven't figured out why this happens, and it only happens to him, but he knows in 15 minutes it's cutting out. And the patient will say, I'll say, well, he's going to go away in 15 minutes, so you push this button when he comes back on and you'll be able to hear him. Well, they just love that because they're getting involved. Fear of technology. Transportation is a big issue where we are, and that's why it's so wonderful to be able to have so many visits in one day. So as many visits as we can do, we may do a behavioral health visit. They may see Dr. Santon. They may see me the same day, get their labs done, just a host of different things, which really works out good. Patient buy-in. Been talking about that, that's key, getting patients to buy in. The cost, we do have charity care to offset the cost. We have patients fill out that paperwork when they come in if they're afraid that maybe their insurances won't cover or if they're going to be charged something. We always do that in the beginning. Here are some of our results, and these were given to me by Dr. Santon, and he started seeing patients 3 years ago, and some of our A1Cs were in excess of 10, and he's gotten them down to 8 or below. That's some great feedback. I mean, it's been wonderful. Same here. We've had some up to 16 to come down to 8. So it's been a great thing. So in closing, what I can tell you is just to campaign for greatness. Make your patients aware that you have the service, prepare them. When I see patients as a CDE, I give them a folder, whether they may be at one of our other sites. So I see them by Telehealth. They have this folder in front of them, so I'm pulling things out and showing them and talking to them, and they have it in front of them. So that makes them prepared for the visit. Communicate with your nurses. Communicate with your staff. Have everybody involved in all the trainings and give them as much education as you can. And it really comes together. So, thank you.
So we'll go ahead and get started back. One thing that come up was the people applying for CME. There's a sheet up on the end of the first table here. If you'll come up and make certain you sign off on that, that'll get your CME credits that you need. For the surveys that you guys done through the app, it looks like 50% are from other or non-applicable, and administrative management 25%. Nursing and clinicals, 14%. Provider, physician, or nurse practitioner, clinical psychologist, or other licensed professional, 11%. And clerical and billing were 4%. You got the other slide up here? How does your organization use telemedicine or telehealth? 30% said frequently, 30% said rarely, 26% said never, and 15% said occasionally. And was there one more on that? That's that it. All right. All right. Well, thank you for the responses. And again, looks like we may have some other folks that we can move along with here. So, Shireen, are you up next?
Hi. So my name's Serene. I work for Finger Lakes Community Health. We're a federally qualified health center in upstate New York. When I say upstate, I mean upstate, not like New York City. We're right over here in the beautiful Finger Lakes region. So if you like wine, that's the place to go. I'm not a wine drinker, so I'm trying to be. We are a federally qualified health center, and we serve agricultural workers. You can see from our data here from 2018, we serve over 28,000 patients. We have 9 clinical sites with several dental sites throughout the region. Even though we're in a very rural area, there is a large request for services in a language other than English, and our staff look like our patients. We're very diverse in our health center. And we are steadily growing because I'd say that our employee numbers, since I've done this presentation, has gone up closer to I want to say we're almost hitting the 300 mark, so we're almost there. So we have quite a bit of issues in the Finger Lakes region. We have very rural areas. We are in the Finger Lakes region, so even though the next town over where our other health center might be not that far away, there is a big, beautiful lake in between us, so we have to go all the way around it. We can't go through it, so we have to go around, so it takes us a little bit longer to get there. So transportation is a big issue for us. We serve a large Mennonite population, so our barriers to I can't even come up with the word when you're you're getting to work and there's traffic. Our traffic is our horse and buggies in our streets or our big roads. So for us, the little triangles there are our health centers, so you can see where the lakes are. And for us to get tertiary care, we really have to travel. Depending as to what health center you are, you might be lucky and it will only take you 30 minutes to get to tertiary care, or it might take you an hour and a half, 2 hours to get there. And if you're used to being in a horse and buggy, that might be a little bit difficult to get there. Or if you are an ag worker or an agricultural worker that came to the area on a bus, finding a car to take you somewhere is going to be very difficult. And for us, that means that we spend a lot of time on the road. So early on when we started doing telehealth services, we were really looking for a way that we can leverage the technology to provide access to care to our patients and keep our staff safe. Unfortunately, because we were so much on the road, we encountered quite a bit of accidents. We had a fatal accident where we lost a nurse on the road. We had a community health worker who had major brain injury. So there was quite a bit of accidents to the point where our insurance carrier said, maybe you don't want to drive anymore. You need to maybe take that off your scope. And we said, if we do that, then we have to close our doors because our patients need to access our services. And they need to get into tertiary care to complete their service and continue to stay healthy. So we have to figure out a different way to make things work. So that's one reason that we embarked in telehealth. But then also we started realizing that it was very difficult for us to maintain our providers in our health centers, particularly very small health centers that maybe we have one provider, maybe 1.5. And if you're a provider and you're young, you're trying to collaborate with someone or trying to get a second opinion, you may not have a group of providers that you can go to and say, hey, I have this issue, I have this patient that has this rash, or this is going on with this client, what can we do? So the technology has enabled us to be able to allow our patients to feel part of a larger community, whether it is building relationships with those tertiary hospitals or just within our own system to be able to have our medical director come in on video and say, oh, let me work with you on this patient, or I can come in and assess the patient with you. So they have that support in the health center. So it helps with the workforce initiatives going forward. So that's a couple of reasons why we have embarked in telehealth. So for us, we started in 2008, we started our telehealth services in New York State. At that time, we did not have parity. We just started doing it because of all those issues that I mentioned earlier. It was better for us. There was a larger return on investment to invest in the technology and keep our patients and our staff safe than to worry about reimbursement. Also, if we were to just talk about transportation, if we had to take patients to the infectious disease provider, if we take 5 people in the car, then we're automatically going to assume that the 5 of us have HIV, because if I have HIV and I'm going to this doctor, then you guys must have HIV too, and we're all going in together. So we couldn't take them all in one car. We had to take one patient per one staff person at a time. So it made it more difficult for us to provide access because it would limit the one employee to the one patient ratio. So we were able to just leverage that that technology to help us with that return on investment. So when we started talking about us doing telehealth, a lot of people just kept asking, well, how are you going to get reimbursed for that? And if we move forward to today, there is parity now. There's more reimbursement. It's not full parity, but it's still improving for us. But the return on investment is greater than just an encounter. We currently have equipment in all of our exam rooms, all of our medical exam rooms, all of our dental exam rooms, and our counseling rooms, particularly because we want to make sure that we not only use the equipment for a clinical visit, but also for interpretation, for education. Our providers are able to use the equipment and say, okay, this is how you use it in an insulin pump, or this is what your pancreas looks like, or whatever video they might want to show. We're able to bring in another provider to come in and support the current provider that's there. Interpretation, like I said before. If we need to call a family member, we're able to use the equipment to do that. So it really helps for us to leverage the equipment to whatever the needs are. And the equipment is really set up based on need, based on the modality. So for dental, it's set up in a dental setup. Clinical, it's set up for a clinical setup, and then for counseling the same way. So the look and feel is the same as if you were there in person. There's no cutting corners in the services that's being provided. Here is some of the equipment. We first started out having equipment on a cart. We had one cart per modality, so one cart for dental, one for medical, and one for behavioral health. Now, like I said, we have equipment in all of our exam rooms. The providers use an iPad or laptop. We have, that's an old dental cart that we have on the wall. We started things being on the wall, but then, just like mentioned before, you have to deal with the issue of now we have that dedicated room for video conferencing, for telemedicine, and if another team uses that room, then you're backed up. So we had scheduling issues. So then we went to the cart, and then there was the issue of, oh, now we forgot to plug in the computer ahead of time and do all of those updates, and the appointment was 2 seconds ago, and now we have to wait 15 minutes for that update to happen. So we tried to work through all of those issues. So now we have the equipment in all of the exam rooms. This is what one of our counseling rooms looks like today. We have a Vigo robot, which is a robot that you can drive from wherever you are. So I can be here. Our Vigo robot is in our health center, and I can drive it and work with the patient. So I can go from the minute the patient walks in, go through registration, rooming into the exam room, pharmacy, filling out paperwork, addressing barriers to care, whatnot, and just stay at the patient's side. We also do digital retinopathy for our patients in our health centers. We like to think one-stop shopping. Again, we're in rural areas, so trying to keep stigma out of people's minds. We can be in the waiting room, and you can see our neighbors there. And it doesn't matter if I'm there to see the specialist for Hep C or HIV, or it doesn't matter because I can just say I'm here for my physical, but I can go to the back room and be seen for much more. We also do teledental and dental exams to be sent out to the specialist. We're venturing into remote home monitoring, and we currently have a few virtual reality systems so that our children can feel comfortable in the dental exam room. Here are some of the services that we are doing in our health centers. I think what's interesting about this list is that a lot of these programs started externally. When we first started doing telemedicine, we were using tertiary providers coming in to provide the care to our patients in our health centers. And now today, a lot of our providers are feeling comfortable working with the somewhat stable patients, like our HIV patients or Hep C patients that don't have comorbidities, and then the more difficult cases they're able to send off to the specialist. So it's more of a hybrid approach where we still do external, but still use our internal, are now using our internal providers as well to leverage what they've learned throughout the years. Here is information about our Hep C work that we've done throughout the years. So every time we find a telehealth opportunity, if you will. And they say, okay, so there's a need for Hep C in our health center. We do a baseline chart audit to see where our current patients are at, what is the quality metrics that we want to measure, and how are we doing them, how are we at them currently without the use of the equipment? Because the equipment to us is a tool. It's a mechanism to bring our partners together and to be able to provide the care to our patients. So we did a national search, and then locally what was there, and then we've monitored throughout the years how many patients we've been seeing and what the quality metrics have been going. Because we want to see, is this technology really beneficial to the service that we're providing, or is it providing more of a barrier? Because in the health centers, we're primary care, so it's the health centers are already busy. I'm not a provider, but when I walk in there and I see the nurses running around, the providers doing their work, it's a lot of work. So for them to be told, now you're going to bring the patient back to your health center, and you're going to be the brick and mortars for the specialists and fill out the paperwork and do the labs and turn on the equipment, it can be hard to get through that hump to get people to buy in and to do the work with you. So being able to show them and say, look, this is what you're doing, this is how you're supporting your patients in your communities, and that's why we're here. We're trying to keep our health centers safe and healthy. Here's our data for HIV work. We have been doing this for some time now. And this data is from the providers that we were doing externally. Late last year, we started doing it ourselves internally, where we started kind of cherry picking the easier cases that we could keep internally and then giving the specialists the more difficult cases. Because throughout the years as we've been doing work, we've been asking for more time from those tertiary providers, and unfortunately, they haven't been able to give us more time. So it's kind of worked where we're being told from a primary care perspective that we need to bring those things internally, but we're also seeing it because our tertiary providers just can't give us the time and can't give us more telemedicine time, so our providers are now doing it internally. I have a little video here to show you what we do for teledental.
You may not be aware of this, but tooth decay is the #1 most common chronic childhood disease. It can lead to bacterial infections, malnourishment, and a number of other dangerous outcomes. For families living in rural areas that don't have access to reliable transportation, it can be extremely difficult to see a dentist on a regular basis. And that makes treating pediatric dental disease an even bigger challenge. Need to Know's Michelle Fowles shows us a high-tech solution helping children who live far away from a dentist.
Look, see? Oh, there's you. Look at you. So we're going to show the dentist in Rochester your teeth, okay? Just like that. See, look. 1 in 3 preschoolers already has tooth decay. And the largest population is low-income, racial and ethnic minorities, children with disabilities, and we have a lot of those people in our populations, and with their barriers, it's really hard for them to get the care. So I will tell you this, Dr. Sean, she's having a little issues with bleeding gums, which is a little bit beyond normal gingival inflammation.
So my name is Sean McLaren. I'm the residency program director at the Eastman Institute for Oral Health for pediatric dentistry, and I'm the interim chairman of the pediatric dental department. We've been doing the teledentistry program since April of 2010. Where do you like to play? On the playground? Oh, fantastic. Do you like the slides or the swing better? For the teledentistry program, our numbers have been increasing every year. We're probably at about 150 or so patients that we'll see this year. We do everything that can be done in the typical dental chair, just we're in an operating room while the kids are sleeping. The kids that we're typically taken to the operating room probably have anywhere from 10 to 20 cavities on their baby teeth, and for a 4-year-old to have 10 fillings done is not that easy. The patients that we're seeing oftentimes have other social issues. Oftentimes they're on some type of state or federal dental insurance. They're usually a little bit lower socioeconomic status, and they have a lot of other barriers or issues that prevent them from seeing the dentist regularly. Oftentimes there's not a dentist in their town that they're living in, or a dentist that accepts their insurance. So what winds up happening is they have to travel 50, 60 miles to see a dentist that's able to accept their insurance, or a pediatric dentist that has the expertise to treat their child appropriately. So through this teledentistry program, what we're trying to do is we're trying to eliminate that, at least that initial visit to the dentist.
My name's Melissa Green. I'm from Red Creek. This is Jason Green. He's 6 years old.
Excellent job. Those are pretty cool ones you picked out there, Mr. Jason.
Yeah, I have a whole monster bag with a whole ton of them.
There's the mesial decay on G.
Yep.
You're doing excellent, buddy. Thank you so much. Open really big. We're almost done already because you are so good at this. It looks like it has a
It looks like resin on L?
Yeah, it looks like it has a resin. Yep.
That was really cool, getting a close-up shot of all of his, I like to call them teeth bugs, and issues that are in there, and the dentist in Rochester was seeing it at the same time. And since that was pretty much an online consultation, we can go right to Rochester and get the work done. We don't have to go there, have a consult, leave again, and then come back for the work.
So Pat will help set up everything with you there, Mom, okay? To help coordinate the appointments and scheduling and everything like that.
Yes.
Okay? All right, well, we'll see you later. We'll see you next time in Rochester. How's that sound? Sounds like a lot of fun. Perfect. Thank you. Bye.
So that clip was done by a local news reporter, and they aired it a couple of years ago now. But the cool thing about the clip is that it really does demonstrate the kind of work that we do. And a couple of fun facts is Dr. Sean and Marlene, who is the dental hygienist that telepresents for him, have yet to meet themselves or see themselves in person. They haven't worked with each other for many years, and we're kind of like joking now that maybe we shouldn't have you guys meet because it's a cool story to tell. But they have not met each other in person yet, but they work quite a bit through video together. A couple of things from this program too is that there's that soft handoff. These kids really feel comfortable going to the OR room and really talking to Dr. Sean because they've seen him via video. So they're like, oh, you're famous. I saw you on TV. Sure, I'll show you whatever you want me to show. So there is less of that anxiety about opening their mouth or being in a different room. Same thing with the parents. We've been able to really educate them and show them what we see, just like Jeff said, and educating kids at school. They don't take our word for it. They have 27, 30-inch monitors that they're seeing their kids' teeth or looking into their mouth or whatever body part it is. And they can really see it for themselves, what we're dealing with, whether there's pus in there or how big the cavity looks. And the tooth really looks big, so it almost looks like the Grand Canyon. So people really see the urgency to get the care taken care of. And when this program got started, was in 2010. So you can see the number of kids that we've seen throughout the years. But what's really interesting about this teledental program is that when we first got started, it was really because, again, their staff found a need. The same kids were coming back with abscesses. They were ending up in the emergency room. We would refer them off to be seen, and they would come right back. So when we did a first baseline review, we identified that under 5% of the kids were actually completing their treatment. They weren't getting in to seek care. And on top of that, there was an 8-month waiting list for them to get in to be seen. So it made access really difficult for these kids. So as we got moving along, we decided to implement telehealth and be able to have them come back to their health center that they're comfortable with. They know where the parking lot is and all those things, because going into tertiary hospital, first you're going to a major hospital, then trying to find parking and which elevator to go to can be kind of stressful for people. So this way they were able to come back here. But even after we implemented the telemedicine program, we found that it really didn't improve much. It went up like 15, 20%. So it still didn't improve as much. So then we incorporated the community health workers, which are the ladies that you saw in the video. Every time a child is referred into teledental, we give them a community health worker to work with them to make sure they address barriers to care, whether it's transportation, interpretation, making sure that they still have their health insurance when they get there. Because a few instances what we had is that they get through the door of the pediatric dentist and then, oh, their insurance lapsed and they can't afford to go into the operating room, so they had to cancel the appointment. So fast forward to today, because our patients were coming in to be seen, they weren't no-showing, they were actually coming to be seen, the hospital started seeing a revenue stream. And they said, your patients are coming in, we're going to give you more OR room time or more opportunities to use the services. So that 8-month waiting period has gone down to 3 weeks. So our patients are able to be seen a lot quicker, they're able to get the care that they need, there's that return on investment of not having to go to the emergency room and use those resources. Kids are staying in school. We're building that foundation between the dental provider and the children so that they feel comfortable going to the doctor. They don't have to worry about anxiety, and as they get older, take medication to go see the dentist. So that it'll be interesting to see as these children grow up and move forward how impactful these visits have been for them. And now we're at 83% completion rate for our kids. So we still have some work to do. We hope to be at 100%, but that's where we are right now. Also, we leverage the technology for administrative services. We our 9 centers are scattered throughout the Finger Lakes region, so making sure that the teams feel united and on the same page is sometimes difficult. So we leverage the resources to be able to have those team meetings, those trainings through video. So all of our sessions, we're able to bring video into the meeting, so it doesn't matter if you're in the health center or out at another meeting or on the road, you can come in on the call and participate in the meeting. So this is our data from February for administrative services. You can see how many minutes our staff spend on video calls, and you can really see by the chart like how many webinars or meetings per day there are, or how many participants there are, and how many minutes in total that are being done in our health center. So for us, it's really easy as an administrator to say, okay, doctors and nurses, you guys are going to use this technology and you're going to be able to do this. We have to walk the walk. So administratively, we use the equipment as well. We don't see patients, but we're able to meet with people, whether they're internal or external, and use the resources and the technology to also make things easier and bring people together. That's all I have for today. Thank you.
Wonderful. So aren't these just incredible champions? So some of these folks I've known for a long time, and some of them are new, and some of I've only met video-wise. So isn't that fun? So unlike these guys, we're little. So we're in eastern North Carolina. So if you head south, cross a bunch of bodies of water, you go to eastern North Carolina. So we have about 60,000 encounters, about 16,000 patients, have only been around for 14 years, and we've been doing telehealth for 13 of those years, and remote patient monitoring. It's because I came from New Mexico, and we did that like we breathed in New Mexico. So my folks out there will understand that. So I'm supposed to be clicking, aren't I? There we go. You'd think I'd be able to handle this. There we go. So that's where we are. That we look like. We're here. We are. We also are a migrant farm worker health center. Agriculture is a big deal for us. So we're majority Medicare. So that's some of our need, and we're an ACO. So you'll hear a little bit about that in a bit. But I really want to show you this video because this tells the story because it's the patients telling the story, and that means so much more to us. We were a BD Building Healthy Community Awards winner in 2014. So
when I get up in the morning, the first thing I do is take my blood pressure. That's the first thing I do after I get out of bed. And then I take my pulse ox, but sometimes my fingers are so cold that I have to go warm them up with some warm water before I can get a true reading on pulse ox. And then my normal routines, brush your teeth and whatever, and then I weigh. Try to weigh with my clothes off because you weigh less. So rewarding to know that somebody is looking after you that's not right there in the home with you.
This rural setting has particular issues. We have no public transportation. So transportation is an issue for us. How do we get folks here? And One of the things I hear constantly from my medical providers and medical staff is, you know, I may not see them again for another 6 months to a year, so that's why that visit is longer. I need to make sure that what they're doing is the right thing, and that's a burden on the system too, because then really what should be a 20-minute visit ends up turning into a 45-minute visit, and we do blood work and we do all the things we do because we're anxious we're not going to get them back.
What telehealth does by putting that in the home is that gives you the information that you have most wanted to know about your patients but really had no way to retrieve. It lets you know what their blood pressures are doing every day. It lets you know what their blood sugars are doing every day, what their weight is doing. And not only that, but because you have the nurse backing that up, it gives you the actual information about what they ate that made that happen, or they had to go visit so-and-so in the hospital every day, and so that's why maybe they haven't been on their medicines for a couple of days and their blood pressure has shot up. All that stuff that 3 months afterwards we're trying to piece together with the patient why certain things might have happened, you have in real time what happened with that.
It makes me feel great that they can monitor him from home because I'm not here all the time, and if his numbers are wrong, whether it's his weight or his blood pressure, they can give me a call, and then we can see what needs to be done, whether he needs to go in for a visit or go to the emergency room.
Healthcare systems fail when people end up in the hospital, when they end up with other complications. We're trying to avoid that by working with providers who are really taking a holistic approach to healthcare and focused on wellness.
We've been able to achieve a pattern of approximately 75% reduction in hospital admissions, readmissions, and emergency room visits for the patients who used remote patient monitoring as part of their chronic disease management. By BD saying, okay, here's some money. We see what you're doing is really going well and you've done the work ahead of time. Here's how we want to make this instrumental. Here's how we want to give value to what you've already done, add more value to it so that maybe that can even grow into a bigger resource for you and for the communities and spread that out even farther and have that ripple effect.
There are so many wonderful community health centers out there that are providing excellent care and have innovative programs, but they don't have the means to really sustain them. And so the support provided by BD and Direct Relief is greatly appreciated, and it really is changing lives.
Are there any other BD award winners in here or Direct Relief? Has anybody applied this year? So listen, next year apply. This it's $200,000 towards your program. So this is our framework. So we've been, like I mentioned, we've been doing this for a long time. And so the equipment that we use in the home is the glucose monitor and blood pressure monitor. You heard Florence talk about that, and the weight scale, so she make sure she's naked in the morning. So we all can relate to that. So the health data is secured. Of course, that's sent over encrypted. Everybody knows about that stuff. We wouldn't send patient information any other way. And so what's really cool is that the patients learn. Oftentimes the patients see their information as they're doing it, and they contact their nurse, and we do use RNs, and they have one nurse case manager that's assigned to them. And Corey will tell you a little bit about that matrix here in a little bit. But that's the same person. So they get Rhonda, Emily, or Deneen, and that's who they see at our health center. So if they have a monitor alert, so that's previously set by the provider. So they set that individual plan of care that is integrated into their record. We are an Epic-based, we're part of the Ocean Health Center Control Network, and so that is a part of their record, and it's tracked. And so if it happens, it automatically sends alert to the provider. And then there are some standing orders, so there's some things that can happen right away. The nurse can recommend a visit and say, I've already got them on the schedule for next Tuesday at 8 o'clock. So that's really helpful. And then every 2 weeks we send a report so that they get an automatic report on how they're doing. They don't have to wait for that 3 months that we were talking about. So as I mentioned, our first funding was in July of 2006, and we've done a bunch of stuff in that time. We are the only health center that had 2 OAT awards back when the Health Center Control Networks worked. And heaven forbid you should do the same thing twice in one OAT award from the federal government. So we had to do something completely different in our second one. And so we did the partnered with another OCHN group out in Oregon. It was the Central Oregon Telehealth Network. I'll tell you about that in a minute. And then we actually worked with a private entity called InScope Health and worked with some self-funded companies because we really had this grand idea. If we could have this as another line of business, then we could support some of our other sliding fee work. We're the 6th poorest U.S. congressional district in the nation, so a lot of health disparities. And so, but that didn't pay off because we were early adopters, and there's still no funding for it. So value-based is here, and this is where we're living. So we just do our patients now. And so Corey will tell you about that here in just a minute. So one of our biggest studies was our very first one that I knew from the very beginning that we better have an evaluation component. So we had the Maya Angelou Center that's focused on diabetes, and Wake Forest Baptist was our separate evaluator, so complete objective, not even part of Eastern North Carolina. And so we had these hypotheses that's what it would turn out to be, and it certainly did. So there's our data. So we had 64 patients in our N initially in the first grant, and at that point in time, it cost us about $5,000 a patient a year. So this was in 2006. It doesn't cost that much now, thank goodness. But that equipment was off the chain at the time, and the vendors overpromised and underdelivered. That was just their MO. And here, look at that. Isn't that incredible? So look at those reductions. So that was kind of the stuff that when I say, oh, listen, I went and got 75% off at the store, where is that 75%? It did not come back to my health center. It didn't go to the patient. It was in the overall health system change because they weren't going into the hospital. We did an anecdotal study on the out-of-pocket cost per patient, and that was about $3,000 a year savings for an individual patient. Pretty incredible, isn't it? Yep. So this was a number that was in 2008. So I don't know what the heck that number would look like now, but I'm sure it would be in the millions of what that cost savings would be if you're talking about that kind of reduction. So the Central Oregon Telehealth Network was an incredible project, and so we got to work with 2 telehealth resource centers, not only Catholic and the Matric, but the Northwest Telehealth Resource Center, Bob and his team there. Oh my gosh. We were on a call for almost 4 years every Thursday, and none of us, except for some of us from the telehealth world, so Kathy and Bob and I have got to meet, but no one else did. So we had Ocean as part of our network, so they were integrated in. And guess what? Today, still this day, do we use an Epic interface? No. It's too impossible to do. So it's just very, very difficult in trying to find it happen. We tried 7 years to do it, and after 7 years, I gave up. That's something for me. But we actually used a different way to get the data into our regular patient record. So we also had the Mosaic Medical, which is another incredible health center out in Central Oregon Bend. Very similar issues, but in the Northwest. So a lot of distance in between, a lot of no roads. So we have a lot of water issues around here, just like they do at the Finger Lakes, but they have a lot of empty space out there and not really good connectivity. So we had 4 different cell services, and our units were 4 different cell companies, so we had to take all 4 out to every home visit to see which one was going to work. And we actually had some old-fashioned, those things that you plug into the wall that are lines, the old line systems. We actually had some of those too, so it was crazy. And that project, if you want to see this, and you actually can go on the Matric website. So we did we did a documentary all during this whole 4 years and did a toolkit. So there's a toolkit on how to do RPM. So if any vendor goes out there and tells you, I'll do this for you, well, you can get it yourself for free on how to do it. Videos, how to start it, how to do everything with it. And that was a part of Matric's commitment, and they had offered some funding in that as well too. So that's what you'll get in the toolkit. All the components that go along with that, devices we used, and the training and the communication, and how to take that to the next level. And this is Corey's part.
Yeah, so this just kind of outlines the process that Roanoke Chowan followed when we were setting up the RPM program. Really pretty standard project management processes. You want to do your discovery work, you want to vet out vendors, look at what is out there on the market, select your product, engage your providers. That's probably where you're going to find some of your biggest challenges. With RPM, probably not so much anymore, but with the telehealth, you've heard some of the barriers with that. And then the follow-up, this is an area where I need to do better with our department. When we had grant funding, we did a lot of follow-up with data and numbers and showing improvement. Since we kind of decided to move away from the grant funding route and really just kind of take this out of Hyde internally, we haven't followed up with our providers as well as we should, showing the data and showing them the benefit of these services, even though a lot of them have been here, been with us long enough to have seen the benefit. And again, just some of the outcomes, I'll highlight just a few for the patients. I really do like to highlight the accountability and healthcare IQ. There is a lot of health coaching that goes on with the interactions between the nurses and the patients. So not only is it just checking on their readings and, you know, checking on general things that you would through case management, falls risk, that kind of thing, but it's also education on disease state process, how they can better manage the disease on their own. The goal is to make these people self-sufficient and ultimately kind of work ourselves out of a job with these patients, get them to be able to self-manage. And then on the provider's side, obviously there's a lot of good benefits there as well. So today where we're at, we're currently at about a 90 patient capacity, and that's just based on the equipment. Should we have the need, we would expand our stocks there. We are looking to expand. We've got a site that we just expanded to this summer that opened up, Crestwell opened up 2 years ago. So 2 years ago, so now we're expanding there with RPM. This is a primary care desert, so it's very important for that site in particular, and we'll look to expand to our new site that'll be opening up in 2019 as well. We do use it in conjunction with our chronic care management billing. So while RPM billing has been slow to come along, CMS does have chronic care management billing that we are able to leverage in certain cases with some of our RPM patients. Multi-channel referrals is really important. So providers have a lot on their plate. This isn't always front of mind. So we have referrals that come in from our behavioral health services. We have referrals that come in from our CDE. The more channels that these patients can come into our program through, the better. We just, in February, issued an RFP for equipment. When you're in an industry that is dependent on tech, it's important to stay current on what's actually available out there. The technology is changing really quickly. So the plan is to continue to do this on a consistent basis, whether it's every 3 years, every 5 years, just to make sure that we're staying current on what's actually available. We do solicit feedback regularly from our providers, so we're trying to streamline our referral template as well, build into our OCHA EMR. Just trying to make that as easy as possible for the providers to give the parameters that they want monitored without a lot of extra steps and extra clicks. Reimbursement, this is always a fun topic. So again, I talked a little bit about we're using CCM where available. Last year they unbundled 99091, which was a step in the right direction. This year for 2019, they've added 3 additional codes. Still some issues around that. There's still not incident to billing, which is a little bit of a barrier. And then for those that aren't dually eligible, there's going to be a copay every month for the services. So that definitely prevents a barrier for some patients if they don't see the value in the services. And then third-party reimbursement is going to vary just based on the payer. And then again, we talked a little bit about multi-channel referrals. We also do proactive outreach to our patients. We use a number of different ways to identify our patients. As being a part of an ACO, we do a lot of risk stratification. We have one of the highest patient risk scores in our area. So we look at patients that have a high risk of ED visit, of inpatient stay over the next 6 to 12 months. We also have a Charlson Comorbidity Index score, which is another risk scoring technique. And we also look at impactability. So with our ACO, we have, they have some sort of algorithm that is proprietary, I guess, but they're able to determine how impactable these patients are. Are they going to be receptive to additional wraparound services? I mentioned again the multi-channel referrals, and one of the things we've really seen some benefit with is we have kind of cleaned up our process. Our local hospital system has a remote patient monitoring program for their inpatient discharges. So we've cleaned up the handoff process for our patients, and we've seen a lot of positive return on that as well.
Thanks. So my favorite story, and I've been doing telehealth for 20-some years, but my favorite story is Miss Lillian. And so Miss Lillian actually uses the internet. She's 77 years old, and diabetes, hypertension, several other things going on. And so she's hooked up with her provider and been doing remote monitoring for a little while. So the nurse who saw her reports every week could see a trend line that every Tuesday, when she did her readings, her weight was up a little bit, her heart rate's up a little bit, her blood pressure's up a little bit. So what's the question you're going to ask yourself if you see that every Tuesday for about 8 weeks? What's going on Monday? So in casual conversation with her check-in, Rhonda says to Ms. Lillian, Ms. Lillian, what do you do on Mondays? Tell me about your Monday schedule. So she goes through it. Well, Monday, every Monday evening, her sorority sisters get together. They go to dinner at the same place every time. So Rhonda says, well, what do you order there? Well, in the meantime, Rhonda's pulling up the menu on the internet. And she says she gets this and this and this. So Rhonda says, well, Miss Lillian, I wonder if you want to think about getting something else. And let me tell you about a couple of things that are on the menu. She said, oh, yeah, I see that menu all the time. So she says, why don't you take a look at, here's some options for you, and here's why, and made a little connection for her. So don't you know, the next Tuesday morning, guess what? Miss Lillian's levels, nothing's elevated. Miss Lillian calls and says, well, if that works there, I bet it will work for other things. So just the little bit of the light bulb, those teachable moments that was just as common as could be in conversation, in relationship, that you would never see in an electronic medical record or never see anywhere else. And so Miss Lillian actually really credited, her family credited, that she was able to live out her life for quite a long time because she had that connection. Now, we do have graduates of RPM. We first started with they could only be on 6 months, and then we learned we needed to do some other things. And so, because those were our grant parameters, and that's why, frankly, 3 years ago, I gave up working with other groups. I just got tired of it. I got tired of grant funding, and I just said, we're going to put this in our budget. In RPM, we budget for about 100 units. And so getting paid would be great, but we've just made the shift. No matter what your payer source is, we're just payer agnostic on this. If this is what you fit it into, and the provider says you need this, this is going to keep better care, better health at the right cost, and take care of all of us. So I will tell you that I just had to shift that. And I think most of us who do this know that those of us who are early adopters, like, okay, just hold out. I said something ahead of time. We're federal government 2 weeks ago, think we're doing nothing, so they keep dropping these grant opportunities out. There's one for teledentistry, and thank God there's folks taking the risk out there. And I talked to our dental school and said, we need to do this. And he said, well, there's no payer structure yet in North Carolina. I said, well, that's never stopped us before. So being able to learn from other people and being in part of these groups, and I cannot say enough about Matric. So that's why I say there's all kinds of opportunities, and if you know anything about what's going on about IA and all of that, I mean, just hold on to your hats because it's happening to us and rather than with us. So we want it to happen with us. So I have to tell you that you all are champions because you're here. And it's important to do that work because you know why? If you know your why, you can endure anyhow. So Viktor Frankl was a survivor of the Nazi camps. And so listen, if he can endure, certainly we can. So I guess it's a good time for questions, Howard. Thank you all so, so much.
And what we wanted to do now is actually we were tasked with coming up with some interactive questions and discussions among the panel. And then we'll take some questions from you guys as well as part of this process. But let's take them sort of in, I'll skip. I won't let everybody start with the same question. So first question is, what challenges has your organization experienced in the initial startup and infrastructure cost for telehealth or telemedicine, and how did you work through these challenges? So Mandy, we'll start with you on this one.
Sure, I'll go first. And again, we're not doing traditional telemedicine as everyone else on the panel. I think we're all doing something very different. But coming from the community health center environment, visits are everything. So again, I think getting that leadership buy-in and sort of having provider champions who really are pushing the envelope and bringing some type of telehealth solution to provide better care is sort of the biggest hurdle. So I think what we've been doing is trying to work again with our CFO and trying to figure out what's the return on investment in terms of bringing these type of telehealth solutions to the clinic and bringing it to the state level. So I know for e-consults, we've been working in Connecticut with sort of our advocates and really getting e-consults reimbursed at the state level, and that's been sort of a several year-long battle, and they were refunding them or reimbursing us for a time, and then we had a sort of a budget crisis, but now they're back to at the table reimbursing us for our e-consult services. So again, just I guess we built sort of a case for why this is necessary and doing sort of that pilot phase of telehealth to sort of say this is something valuable, there is a return on investment, but again, it really takes sort of the champions and the leadership buy-in to get that going. But that would be our experience in Connecticut.
Jeff?
Okay, I've talked about some of the challenges. One that I did not mention really was, like you said, the leadership, the buy-in. Technologically, we overcame a lot of hurdles early. We were able to get the equipment. We were able to get the networking. The biggest issue at that point was getting a provider that really bought into the vision and would use the technology. I specifically think of a situation with schools and therapy. We were in so many different schools with school-based psychotherapy, but we did not have any of the providers that were willing to try the video option. So for years, we were still traveling between sites, spending a few hours at each school, wasting a lot of time on the road when we could have been seeing kids by video. And so once we found providers who were willing to use the technology, that really opened doors to other options.
All right. Carla?
I really feel like Dr. Santon helped bring our providers on board because he came on the scene and was able to give our patients some care that they would no otherwise, they couldn't have experienced it. I mean, going to UVA to see a endocrinologist would be just simply out of the question for our patients. And when he came into the picture, it opened up a whole, I felt like a whole new world for our clinic because our providers were more, they bought into it. They were able to talk with him about certain cases and collaborate with him on a regular basis, and I think it just led to our telehealth really coming on strong. So.
Serene?
Hi, thank you. A couple of things. So early on, what we encountered was funding, right? So we were able to, through the different funding sources, whether it's USDA, Rural Health Network grants, we were able to acquire the equipment. But what we found interesting early on, or not early on, I guess it was more later on that we identified, because I would always tell the staff, you go to your neighbor's house or your friend's house and you can pick up the TV remote. It might look a little bit different, but you know what it does and you're able to figure it out. So even though the equipment doesn't look the same at every health center, it's the same concept, so you'll be able to use it easily. Well, a lot of our staff travel between our sites, and again, these are very busy sites, fast-paced. So no, it's not that easy. And with turnover and with staff going between the sites, we learned that even though grants might be a little bit different, I think we learned that it's important to stay with the same equipment that you purchase. Even though it might be a little bit more expensive, or you're not sure if you're going to be able to get it, once you invest in a particular device, you have to stick with that device because it makes for that easier buy-in from your staff, easier training, and they're able to go from site to site and everything looks identical, everything looks exactly the same, the remote looks the same, so the staff have easier conversations with the IT team. Even the cables look the same. If you need to do an Ethernet cable, we make sure that it's the purple cable that you have to plug in, and where is it plugging into. And even now today with the different grant fundings that are being out there, we make sure that we purchase the equipment, or if we are going to replace the equipment because equipment has gone down, the prices are cheaper, better, the quality's better, that we replace the equipment that we have now and maybe use our old equipment to a specific group, so that that particular group, whether it's your care managers or whatnot, they use that specific equipment, but your nursing team sticks with the same devices. So that was a hurdle that we painfully overcame and learned with a lot of frustration, not only from our clinical staff, but also from our IT team, our training team, trying to retrain staff, making it a lot difficult for us to have that buy-in. Return on investment and reimbursement has been mentioned before. Early on, when we tried to get our partners involved, the biggest question was, how are we going to get reimbursed? And parity wasn't there. And what we learned is that we do it, even though the reimbursement, the encounter reimbursement isn't there, and identify how are you providing savings. And it, like Kim said before, it might not come to our health centers directly to us, but it comes to the system. And as value-based payment comes through and value-based care comes through, eventually it will catch up to us. And we're fortunate enough that we have been doing telehealth for some time now. And it's going to be easier for us to just easily be able to submit the claim versus trying to figure out how to document, how to have the telehealth visit, how to do everything at once, where now for us it's just a matter of how do we submit the claim, because everything else has already been set up there for us.
Kim and Corey.
Sure. I don't know if you could go back the slides, but I forgot my last slide, and that's part of my answer. I don't know, Ben. And Ben, you are a hero to me. But the establishing innovative partnerships, so we did it's a Z in logos is basically what it is, because really showing value to your partners. You don't have to do it, Howard. I can just, because really what happened with us, with our partnership with our local health system, we brought them into one of the state grants. They didn't even think about doing it. We said, listen, come in with your heart patients from the Heart Center. That's that wonderful logo. So we said, we'll pay for the grant. We'll be the fiscal agent. Let's work with the Heart Center. So we got their nurse practitioner involved, and about that time, timing is everything. Guess what happened? The legislation came down about the 30-day readmit penalty for hospitals. So just about that time, we were able to show them the first year's data, that all their patients who participated, there was over 200 of them. Guess what? None of them had a readmit. Not a single one had a readmit in 30 days. Guess what they did? Their next year's budget, they dedicated over $1 million to what? RPM. So they do a much more fixed process. They do 60 days. That's all they'll keep a patient on. Then they link them if they're one of our patients, which they love it. When they're one of our patients, they link them to our RPM, and we make that continuity of care. And of course, we're on the same EHR, which we can have the care everywhere back and forth. So showing value to your stakeholders and partners, and bringing everybody you can bring in on the boat to help understand as well too. And then their foundation actually funded us to special populations with RPM. So and which we still get. So those are the kind of things of sometimes we're just so busy doing what we're doing every day, we are afraid to get out of our lane, and you just can't be. You just got to get out there and have other partnerships. Anything to that? Nope, he's got it.
All right. And just to piggyback on something Jeff put in his presentation was the cost of the initial cart and that equipment that goes on it. Today that cart probably cost you about $12,000. 18 years ago, that cart would have cost you $75,000. So technology's changed and the cost has gone tremendously down. So don't let the cost be one of the prohibitors that you look at. Second question is, and Jeff, we'll start with you on this one. Do you have any concerns about using a television doctor with the mentally ill patients?
Yeah, we do get that question quite a bit. And again, if Dr. Perry were here, I keep mentioning him because he's got some great answers to these things. But he makes it very clear that he's had no issues with patients not accepting the service. And he feels extremely comfortable with it. All of our docs that are using it feel extremely comfortable with it. One of the most common questions is, well, what about this severe, kind of the schizophrenic, the patients like that? And again, I'm not a clinician, so I can't really go into the details on that. But he said, one situation we had was the patient came out and they were just they were in such a good mood, and they were telling their family, see, the TV does talk to me. And it was just kind of a click that, this is kind of addressing the patients where they are. And it was, he's had exceptional feedback from it. The only no-shows really, or the people that have scored it low, have been people that are drug seeking, because we're very tight with what we prescribe, and he just won't do that. And so, of course, they don't like him.
All right. And Carla? As it moved to Carla's response, I'll tell you, Dr. Santon is an older physician, and he refers to the work he's doing with endocrinology as television medicine. So,
to my knowledge, we've not had a problem. We have an excellent behavioral health team. Our nurses, too, are very close to our patients, and, we'll go in the visit with them. We'll make them as comfortable as possible, even if it's a behavioral health visit, if that's what the patient wants. But to my knowledge, we've not had a bit of problem with that.
So what we have in our health centers, we haven't moved into home-based care. We have the patients come into our health centers, and we just have made procedures. We've placed procedures so that if there's an emergency in the room, so for us, our patient is in the room alone. We room the patient where the nurse will place the patient dependent as to what the behavioral health provider wants, whether they want the full view of the body or from the waist up or close up. And we let the patient know where that nurse is going to be should there's a need for her to be pulled in. Then there's also procedures that the distant provider can do to access the nurse as well. If for whatever reason, let's say the patient faints or locks himself in the room or whatnot, the distant provider has direct access to our nurse. So they're not going through the call center or through the front desk, and maybe that front desk person doesn't know who she is, who this provider is, and who she's trying to contact. So we have processes in place so that they can get directly to the telepresenter, and that telepresenter can get into the room right away. So if there's a suicidal patient in there or whatnot, there's quick response protocols that our staff follow that will help that distant provider. What we have found for us is more on the opposite end, not particularly for behavioral health, but more for like specialty care. It's difficult for the providers to not touch the patient during the visit, right? So they have to trust their telepresenter and know that that telepresenter is a person that they can rely on for the clinical visit. So what we have done is invested time for telepresenters to spend time with the clinical provider if that provider feels uncomfortable of letting go of that patient. So we invite the provider to come to our health center, look at the equipment, look at our rooms, spend time with the nurse that is going to telepresent with them, or the provider. Sometimes we have providers that telepresent for the specialist, so that they can start building that relationship and really collaborate together as a team, because it's I guess, difficult for a provider to let go of not physically touching the patient and really relying on somebody else. But just building those special processes or policies so that should an emergency happen, that distant provider has access to the key staff to address any issues that come through.
Kim and Corey?
So with our RPM, we don't have that issue. I can go to the next question if you like about the monetizing or the opinion about primary care access for offsite without a nurse. I think one of the components around that particular, and we're all seeing it, if we're self-insured and our vendor actually provides telemedicine appointments for our employees. And so, which works out fine. They're primarily sophisticated about their health care. They can access their own record. Most of our employees have MyChart and have portal access. But I think those of us who are working with special populations and vulnerable populations, to your point about having a community health worker or a linker or a navigator is so important, especially working with vulnerable populations. So I think the technology is great. I've used it myself and think it's wonderful. I do think as we're trying to keep focused on, making sure folks have a medical home, that's a part of that too. So it's just a tool, as Jeff mentioned. It's a tool. So I think keeping our own thought processes around what's out there and using it to our best ability, but remembering those of us who serve the vulnerable populations.
Mandy, you want to respond to that? Well, actually, same question we had, if you want to respond.
Yeah,
to that
so
question.
we're not actually offering, I think, to the behavioral health question, we are a provider-to-provider telehealth, so I can't really speak to sort of, treating the mental health issue because we're not doing that for our telehealth intervention.
All right, and if we could, let's take a couple more that were presented to our group, and then we'll go to the ones off the screen here. But one of the other questions we had was, what are some of the community partnerships or initiatives that you've seen started to address the lack of broadband service in rural areas in particular?
And again, I'm going to have to defer to the panel on this one since we're actually not in a rural area to offer telehealth. We only actually have 2 rural school-based health center sites in Connecticut. Connecticut actually doesn't qualify as rural, and so we actually don't have broadband issues. We have other, equipment issues and sort of, user issues that we need to overcome. But in terms of broadband, that's not one that we're encountering.
We've utilized the federal programs, the Rural Utility Service, the USDA funding wherever we can. It really is a hassle to go through the application process for those. But we did find we were able to get some substantial savings. And most recently, we've collaborated with a more of a national group so that we can be considered part of a collaborative venture rather than doing it on our own. And that's helping us get access to some additional funding.
Well, we're so fortunate to have Howard on our team, and he's always looking for different ways to get us funding. And UVA has been a great asset to us as far as providing equipment. I can't say enough about them. They have really helped us step up as far as telehealth is concerned.
We've leveraged the federal consortiums, communication consortiums, to allow for broadband at a cheaper price, lower price. And then also, what I'm seeing in our communities is that there's digital inclusion networks being developed, because for us, when I had gone to my first meeting for this network, I was looking at it through the healthcare lens as to how we can provide access to care to our patients. But I learned that it's broader. The broadband and internet access to patients is more than just being able to provide remote home monitoring or direct-to-consumer services for our patients. It's more of digital awareness and learning. So there's our rural schools, our children are having difficult time keeping up with the rest of the students if they don't have access to internet in their home. So there's some really neat networks that are being developed just to be able to bring broadband to every household, which for me, it's going to help the healthcare world, but they're looking at it in a broader point of being able to have young families be able to have access to broadband so that they can know how to use it, how to leverage it for education, filling out job applications online. So it's like a bigger thing than healthcare to provide access to internet for our communities.
So in our community, our local electric cooperative has been taking advantage of some of the grants available for last mile broadband access. We're in an area where roughly 70% of our patient population does not have broadband access. But in addition to just providing the broadband service, they're providing kind of concierge services where one of their representatives will come into the home. They'll help them get connected to what they call high impact services that will help them better manage their electric bills, some of the utilities. They have access to some other programs that will help with housing. And for us, that really helps them address some of the social determinants that we see in a lot of our patient population. And we're also looking at an opportunity to leverage that to potentially get more of our patients engaged with our patient portal as well.
All right. And just to piggyback on what Carla said, one of the things in our area, when I've been with Tri-Air for a little over 7 years, and when I went there, they had a T1 line. And I said, you know, there's fiber hanging on the lines out in front of the building. And they said, no, there's not. But with the tobacco indemnification money that come to Virginia, they had a tobacco commission, and they've hung fiber all along the major primary routes in the Tobacco Commission's region. So it's hanging there, but it's dark fiber. Nobody knew it existed. Nobody had asked about, you know, connecting to it. But, you know, again, it's knowing what resources exist in your areas sometimes. And I don't know that there's a good inventory of what actually exists in a lot of these rural communities. And I think this next question we've sort of addressed in some of the presentations, but I'll ask if anybody has anything else they want to add to it. But how did you shift the culture in your organization to embrace telehealth interventions, particularly among your care team or provider, from a care team or provider perspective?
Yeah, so I can speak to sort of our efforts in implementing e-consults at our clinic, but also we work with clinics across the country and trying to figure out how to implement sort of the asynchronous e-consult telehealth intervention. And like I've said in my presentation, the less clicks, the better. So we actually have account managers who work with each of our sites and each of our provider teams to sort of work in the e-consult workflow so that it's similar to as if they were to do a face-to-face. So depending on the clinic, we work with either is it the MAs, the nurses, the providers themselves, to really sort of figure out a workflow before we implement that would not sort of interrupt what they typically do. So it's no extra time for them to do it. And we actually do trainings for the providers. We, again, assign account managers to be in touch with them. We identify primary care providers on site who sort of want to champion this issue. And they've been really sort of the key to success to remind providers this is a service, or if there's new providers who join a clinic. And as soon as we see a provider who starts submitting and getting results, it spreads. So again, identifying the champions is really the key issue.
One thing that we've been just recently started doing with a lot of our patients, and some of them don't have computer access in their homes, they don't have iPhones or anything, but continuous glucose monitoring. Some of the companies out there now are providing ways for you to bill when patients come in. You can have them come in and help them get this started. Then they bring their transmitters to you to have them downloaded to go to the provider to go to the cloud, and Dr. Stanton can use that data, and we also can bill some insurances for that too. So it's a win-win for the patient, the provider, and for the clinic as well. But it's really nice that he's able to get that data, and without the patient having no access otherwise to computers and getting data to him, it makes it easy.
So for us, I think what we have done is it all starts with onboarding. Our cultural shift has been a couple of things. First, our CEO has been very much vocal and pushing these initiatives forward. We've been looking for champions on the front end patient service that have the direct contact to our patients. But then also when we're onboarding staff, we let them know right from the get-go when they're applying for a position that we do quite a bit of telemedicine, quite a bit of video conferencing, and that's the culture that they're coming into. When they are training or becoming acclimated to our health center, there is training on what video conferencing equipment we use and giving them the opportunity to leverage it. We have our phone system is linked with our video conferencing platform, so you can do video calls directly point to point. We use our Outlook has platforms that you can do within Teams and different features in there to do video calls with your teams. So we make sure that the staff know about this so that it doesn't become a barrier for them to be able to communicate with each other. They are able to share their screens and be able to work together on a particular case. It doesn't matter what focus they're doing. They're able to look or be like if they're looking over each other's shoulders when they can be in two different health centers. So we've been able to push the needle forward and build and change the culture to make it look almost like I don't know if you guys remember when cell phones first came out. It was kind of like hard to think that you're going to have a cell phone with you, and now, if I don't have my cell phone when I leave the house, I turn back and get it because I feel weird without it. So to us, video is coming to that point where it's the new normal for our health center, where you're in a meeting and there's someone always on video, that if you need to talk to somebody, you have the option of doing a video call or sharing your screen. So it's having that continued training and conversations about how they can leverage the services, not only for clinical care, but also for other lines of business as well.
I love what Mandy said about keeping the clicks down too. So I'm a psychotherapist by training, and so I know what it means for moral despair and the components around what we do every day, and it's just something, So trying to do as many standing orders, like Corey mentioned about our risk scoring, that it's just if it comes up in the algorithm, you get it. I call it the Grace and Grits program. You don't have to ask for it. You just get it. So so as much as we can do around those kind of things that are no wrong door for our teams and our patients, I think it really behooves us to not use the technology that way.
All right. Anything else among the panel? All right. And the final one here is how do you get leadership buy-in to invest in the telehealth? And Carla, I'll start with you, but before we do, I'll tell you something probably Carla didn't know. We had met with Dr. Stanton several times before we ever started the program with the endocrinologist at UVA. And the director there at the time was a very hands-on micromanaging director, CEO. And she was always invited to the meetings. And it got to the point where that day, the meeting with Dr. Stanton, we were going to have to commit resources and time and staff. And she come to me and said, well, I see where you got this meeting today, and I've not been invited to any of those meetings. And I said, that's not true. You've been invited to all of those meetings, and I would encourage you to drop whatever else you're doing today, but you need to attend this meeting. We've got to commit resources today. And so we met with Dr. Stanton, with all the staff. Doctors and nurses were all enthused about this program. And then she and I met with Dr. Santon afterwards, and she said, that's really a neat program. I think that could benefit our patients. I said, it is a neat program, and we need to commit to this today. So, but I know Carla didn't hear that, but again, you've got a busy schedule as a CEO, and again, to drop and listen to some of the things that actually go on in your center, you've got to take time to do that. There's some good opportunities to pass you by if you don't.
Well, with Dr. Santon, surely that helped me get more involved with telehealth, because when we would see a patient together, of course, I would be there with him as his nurse, telling him the patient's vital signs and just what he was seeing the patient for. And then as soon as the visit was over, lots of times he would say, well, I want you to see this patient, for education as well. So that kind of opened the door for me as far as the CDE, because I had just recently became a CDE. So I started seeing patients from all 3 sites, well, the other 2 sites that we have, and our site included. But it just made it really nice as far as being able to reach out to our other sites and do telehealth with them and be able to see those patients for other providers and for Dr. Santon. So. And it's been going strong ever since, and we've had other specialties at UVA that our patients have seen as well. So now we've gotten most of our staff on board. Most of the providers are comfortable now with telehealth. Behavioral health has been a great asset to us. They see a lot of their patients from all of our sites through telehealth. So I just feel like every day we're getting more on board, and most of our providers are getting on board as well.
So, on one hand, I would say that we're very lucky because our CEO has been the one that's been pushing and having us be really on board with telehealth. So that's been a plus. And we would think that it would be really easy to then put initiatives forward, but we've gone through a few CMOs and getting our providers to buy in and to continue to do the work has been difficult between our CMO and our nurse manager. For us, the nurse manager is mostly who we deal with because it's the nursing that telepresents. So having that nurse manager on board is it takes time. We just got a new nurse manager a couple of months ago. So the change in the positions, it just takes time, I think, for them to wrap their head around it, particularly if they haven't done telemedicine for some time or never encountered it before, and being able to really understand how it affects their staff and how it benefits our patients. But it has been beneficial that our CEO is really on board on it, and we're being able to leverage the grants and the resources that are out there has been beneficial. But one way that we continue to engage our providers is by having them participate in the services that we're doing. Either we encourage them to telepresent, even though it's not necessarily cost effective because now they have a little bit of downtime when they could be seeing a patient themselves. But there's training and education that they're able to get from that tertiary provider. And then, like I said before, being able to build relationships with those providers to have somebody to kind of bounce ideas off of has been helpful. But also when we're looking to replace equipment, we have them look at the equipment and we give them options to pick from, because then this way they have bought in and said they are the ones that actually picked the equipment. It wasn't myself or my IT team saying this is what we're going to go with. They've actually picked the equipment, played with it, looked at what would be beneficial for them to use. So they have some say into what services we're providing. And all of the services that we're providing in our health centers has been based on need, based on their asks to have these services placed. We've been wanting to do dermatology for some time, but there hasn't been a need. And because there hasn't been a need, our providers haven't referred patients to do dermatology through telemedicine. So it really has to be provider driven to implement services for us.
Everything they said, and I am the CEO, so that helps. And Mary's the mom, and Jeff can talk about that. But I do think, thinking about other revenue streams that complement what choices you make. So we have a very robust 340B because of our payer mix. So making some decisions around getting a provider trained in Hep C so that we could do that. We did with telemedicine, and that reimbursement on 340B actually can fund significant amounts of RPM. So, trying to, piece those puzzles together, I think is the challenge that we need to get help from large, like Matric and other resources and legislative pieces too, Howard.
All right. You guys got any?
I will just say, and I know several of us talked about it in our presentations, but building evaluation in at the beginning is really key. So, even if you're you don't have the funds to really, put towards these initiatives, the more data you can collect, the better in terms of both leadership buy-in to keep them, if you have a change of leadership or, just keeping leadership interested in sort of putting in the investments, the staff time, and again, sort of promoting this throughout your agency is just really important. So again, building that evaluation and at the get-go is really important.
I know for us, in order to get it supported from the top, we really had to look at what were the issues that needed to be addressed. With Dr. Freeman, our CEO, access was a big issue. And so if we could find a solution or a way that patients could access care in some of these more remote locations, then it would be something that was supported. If it was a way to improve the quality of care, where they could have a higher level provider available, or our primary care docs could have access to a specialized psychiatric consultant. I mean, those were the things that helped us get buy-in from the top, was addressing the things he viewed and the board viewed as of major importance for the organization.
All right. Well, these are some of the questions that prompted up from the app. So what is your opinion about providing primary care access for patients off-site without a nurse? And again, I'm assuming this is some of the home monitoring that may be going on. So, and I know some of that technology is pretty sophisticated now.
So I'd like to say that I think that we really don't have a choice, at least from my perspective as a primary care provider working for a federally qualified health center. Everybody around us is doing a direct-to-consumer, right? Insurance companies are saying you can just go on and dial and we can assess and give you service. There's services out there like Teledoc that you're able to use those resources to address pink eye, if you will. And it's not, we'll see you at 4 o'clock, we'll see you right now when you called in. So as I look at our organization, as these other entities come into healthcare and become more robust and more common, I am fearful that we're going to get stuck with the visits that require a lot of the resources, and yet we still get the same level of payment. We need those sick visits, if you will, to help offset those visits that pull so much resources. So we have to be involved and be able to give our consumers, our patients, what they want. Myself as a patient, I love the idea of being able to call my provider on my iPad and say, this is my symptoms, this is what's going on, this is what my eye looks like, or look in my mouth. And then my provider can tell me, yep, come right in, or here's your prescription, off you go. So I think that, first, I guess, again, I'm not a provider, so I can only speak from my perspective and with my opinion. But I think that as a healthcare industry, we have to stay at the cutting edge and really be able to stay competitive. Otherwise, we're going to be really stuck with those difficult cases. But then also, I think that we can leverage these resources and, like Carl was saying, push encourage our patients to use their patient portal, because they are being more engaged and more aware by either their wearables or just Googling whatever symptoms they may have. So they're already engaged in looking at what's going on with them. So being able to provide that access to to their provider is helpful. But then also as a healthcare provider, we can look at how we can leverage these resources to be able to support the patients. So one thing that we are doing right now too is that we are arming our lay health staff that go and visit people in the home, and have them have an iPad, a laptop or an iPad with the peripherals, and be able to go do a home visit. And if they identify someone that's sick, that they can call in to see the provider. Or if there was an emergency room discharge, the nurse can go into the home and see a patient from their home and be able to say, you know what, that cut or whatever, that wound looks a little bit funny, let's call the provider and see what's going on. So we're able to give a little bit more care and leverage these resources and keep the patients in our system and have them continue to build that relationship with their primary care provider instead of seeking support elsewhere. Because as a consumer, I want to continue to see the primary care provider that has been seeing me for many years versus just calling somebody else and then just having a random person tell me this is what's going on and let me send you this prescription, even though it might seem appealing because it's more time effective for me as a consumer.
Can I make one comment? I'm sorry. I don't want to break protocol, but and I can give you guys an example of, we had a patient come into our office, be seen for respiratory symptoms, seen by a provider, examined by a provider, and not happy with the fact that they were not it wasn't deemed clinically necessary for them to get a prescription. Go into our waiting room, call Teledoc, and get a prescription in our waiting room before they checked out. So as a provider, I have a problem with that because now I'm being asked as a provider to provide that same level of poor service, in my opinion, to my patients. And I just don't think that's a true medical home or a true clinical setting. And it's hard for me to feel good about pushing that on the providers that I supervise to say, I want you to allow your patient to be able to call in and just tell you what's going on. You look at them on the screen and say that's as high a level of care as they would get if they were in your office. Just want to point that out.
No, I would agree with you. That's why I'm saying that I think that it's, as a consumer, I want to see the same provider that I've been seeing. And if my provider feels that I need to come in, then to be able to allow to come in or to come into the health center. I think, unfortunately, we are dealing with those teledoc organizations out there, and until something, unfortunately, I think what's going to happen is that there's going to be something where it's going to be poor care and a poor outcome is going to come out, and then the question of whether telemedicine is something that's beneficial or not is going to be questioned and potentially brought up into the legal systems, and what it's going to affect is the people that are doing their job correctly, right? Because we're saying you want to make sure that you're not cutting corners. This is just a tool to be able to provide the same level of care to your patients and being able to cut or bring them closer together versus having that time distance in between. Because in the work that we have seen, our patients have the quality outcomes have just been so much greater. If the equipment not been there, we wouldn't have been able to provide that same care. But unfortunately, that is what we're competing against, and figuring out how do we educate our patients to say, look, yeah, you have the opportunity to go and do teledoc, but just remember that they don't know your full history. They don't know what other medications you're taking that could be indicative to what they might prescribe. So it's better if you come and work with us and have you be seen through us. But if we're not able to even provide that opportunity, then we're going to lose that patient even faster. They're going to just build relationship with those other entities and come to us when it's really something more difficult that the other person isn't going to be able to address. So keeping them in the system, I think, is key to be able to say, okay, well, we have this, we can give you that same opportunity and give you the option of doing the direct-to-consumer work, but we want to make sure that we are a partner in your care, and you may have to come in to see us. It's not going to be as simple as, yep, we're just going to give you this prescription and off you go on your merry way, because we truly care about you. So it's having that conversation, I think, with our patients and that awareness that's there. But for us, I think as a business, I think it's something that we really have to at least be knowledgeable of that it's there, and that our consumers have those options.
Yeah, and at the NAC P&I this week, I was on a panel that addressed telemedicine in community health centers, and that question actually come up then about the teledoc. I'm a strong supporter of telemedicine. I am not a strong supporter of teledoc. I think from the perspective of any time you generate a legitimate encounter, it has to be based on a patient-physician relationship, and you cannot do that by calling a number, and for the top 10 maybe diagnoses they have, they'll write you a prescription for that. I just don't know how you can justify doing that. So, but that question come up in that session as well. So, again, I am not a supporter, and I bet you most of the folks on this panel are not either.
I would say I think the incentives are that kind of incentive around the use of a quick answer in the direct-to-care market is a misguided incentive. And I think that's what we are also, as you mentioned, that we're competing against, of understanding the medical home model. And I mean, because it happens in the in-person care. In the large practices, one of our pediatricians came from a large 50 pediatrician practice, and because they are incentivized by number and not by outcomes, that, you know, they're competing against a pediatrician. Oh yeah, I'll give you that antibiotic, and the ones, no, I won't. And so it still happens in the industry of what one determines a care is or not a care. Again, a wrong incentive. So I think that's the piece that when we're clear about our why, then the how is there. So my why is not to check off a box and get someone to care. My why is the bigger picture, and I think that's the piece in the industry, Howard, that you're referencing.
And I'm gonna take a stand on the opposite side as a teledoc supporter. And just remember, I'm a CFO, and we provide health insurance for all of our employees. Our employees love it. Our physicians don't, because there are concerns about the quality of care. What I see is it's keeping people out of the ER. It's reducing our cost of care. Our employee satisfaction numbers have gone through the roof having quick access like this. So it's one of these things, it is such a market-driven thing, and we have to compete against it. And so our approach is still in process, but we've got to view it on a continuum of care. There are some patients that our docs feel completely comfortable dealing with over the phone. They've seen them for years. They know kind of what they're dealing with. A phone call is completely adequate to generate a useful medical encounter. For others, they want to see them face to face. For others, they want to touch them. So we've got to be able to provide that full continuum and still somehow keep that satisfaction level. We got to provide what the patients want and what they need. And so we've got to help educate them on what they need versus what they want. So this is going to be a battle, I think, for several years. But like you say, it's there. We're competing against it. And I, for one, as a user of Teledoc, I've not been disappointed. My wife used it. The second time she called over the same issue, they said, now, our protocol is we can't go any further with this. You have to go see your primary care doc. And so there are some protections. They're certainly covering their tails. They're not going to get sued over something, I don't think. But it really is going to be a battle for us because that's the world we're in.
I have something to add real quick. The thing that concerns me, and this is coming from a nursing standpoint, because I've been a nurse for 30 years, and I listen to heart sounds and I listen to lung sounds, and I'm interested in that patient, and it's just hard for me to wrap my head around that a device. I mean, what if there's artifact? I mean, what if they're hearing something that really isn't or is there? I mean, that concerns me. I just don't know if a piece of equipment can be what a provider or a nurse could be in the care of that patient, and that's my big hang up with it. But the concept is good, and I mean, and it's going to be great if it can be like in the patient-centered medical home. It can be with your provider, your staff. But when, like you say, when you reach out and it's this doc in the box somewhere that you don't, that knows nothing about you, and you could have a host of problems. You're diabetic, you've got congestive heart failure, you've got all these things going on, I'm just afraid things can be missed, and it's a concern.
My last comment about that is it's a tool, and I've made a lot of messes using the wrong tool for the job. So I think it's something we're going to have to be careful about.
And I would think too, you know, one of the other competitions we've seen are the urgent care centers. And in our area, one of the things we're seeing now is a disincentive by the insurance carriers for using urgent care centers. If we see a primary care provider under our insurance, it's a $25 copay. If we go to an urgent care center for the convenience or whatever else, it's $75 copay. So there's a disincentive for using urgent care in our area at this point in time. Second question off of this is, how do you monetize telehealth consults, private pay, donations, or Medicaid? Anybody want to take a stab at that?
So early on, we used our revenue to help support the cost, but now we're getting reimbursement through some Medicaid, some commercial insurance. But I'm in New York, so and it's taking us a long time to get where we are today. So for the states that don't have that parity or don't through Medicaid right now, for us, we just had an update that came out in February that the patient can be in their home or be wherever, under a bridge, wherever it is that the patient is located at, and we can get reimbursed. But it's taking us time to get where we are, providing the data and having conversations with the key players to the point where we actually drew pictures of this is where the patient is and this is what the equipment's being used and this is where the doctor's going to be, because wrapping their head around it was difficult at the state. We invited people to come to our health centers and we did mock visits so they could really understand what it meant to provide these services. Because for us early on, when we provided the telemedicine visit, we would only get reimbursed $25 for the originating site. But we do all the work. We do the blood draws, and we do the appointment management, and we do the rooming, the transportation sometimes, the interpretation, and we only would get $25. So luckily that has changed for us, and we still have room to grow. But I encourage other states that are not there yet to not give up. Keep having those conversations with your legislative people and your state people.
What do you do for your uninsured and your sliding fee patients? How do you pay the specialists?
So what we had for us early on, remember we started doing telemedicine in 2008. And when we got started, when Finger Lakes got started, we were a coordination unit for our agricultural workers. So what we didn't have, at the time when we got started, we didn't have providers. We had the support staff that drove and transported our agricultural workers to get care. So then eventually we became a full federally qualified health center and provided care. Then we started looking at doing telemedicine. When we started doing telemedicine, we had those relationships built with those tertiary providers. So what we said is, hey, okay, pediatric neurologist, we'll give you equipment. And this is a big major hospital. We had our little IT folks go to this pediatric neurologist office, set up equipment at their facility, teach the provider how to use it. And so we said, we'll teach you how to do telemedicine because you can then leverage and be available to many. You can, once you learn how to do this, you can fan out and give us a reduced rate for the visit because the patient's going to come to our health center. So that's why I'm saying that we used our revenue to pay that specialist. But our return on investment was that we were not putting our staff at risk in the field. They weren't driving the patients over there. So we already had that cost. We had the driving cost, the interpretation cost. So we kind of balance the two because we're paying that specialist, but now we're able to leverage that employee by bringing more patients into our health center, and it could be for whatever, and they can fill the car up and bring them into the health center because there wasn't that concern about HIPAA or stigma because they're just coming into the health center. So we kind of had that expense already, and we saw that return on investment for us by paying that specialist. But then also, like I said before, we also leveraged the equipment for our meetings. So our provider meetings, they did not stop what they were doing and block off half an hour, maybe an hour for travel time to come together in one area, meet, and then travel back. We had them meet via video, so that 1 hour that we used for driving to that meeting was now being able to be filled with patient visits. So we had extra revenue coming in that way because we leveraged the equipment to help with having the staff meet, and we did that for everything, whether it was nursing, whether it was admin folks. They were able to meet virtually versus meeting in person. Not that we don't meet in person, we still have meetings in person and have, we have quarterly meetings where our health centers close for half of the day so that they can have that interaction, be able to do, because we don't think you can do everything via video, but it definitely helps and helps offset those costs. But that was early on, but now, like I said, we're getting better at getting some reimbursement. And we were just happy when the parity law came out that the third-party providers could bill, because then we didn't have to pay for them. We didn't have to cover those costs. But that's how. Yes.
Yeah.
Yeah. Yep.
And just from Virginia's perspective, and the most what we use are the University of Virginia, and most telehealth regulations are driven by state, whatever that may be. And I was just talking to Jeff earlier. We used to be part of the, in my former position, used to be part of the Tennessee Primary Care Association, and we done presentations down there about telemedicine, telehealth. In Virginia, a state-supported medical school is funded by the Commonwealth of Virginia, and they have a provision for doing indigent care. So in Virginia, they pretty much have a sliding fee scale that allows them to discount for our patients that we refer to them. We went to Tennessee and told them that down there, and they said, we can't do that in Tennessee. Finding a panel of specialists that we can use is a challenge. And, and I had connections to some of the medical schools down there, and I asked them, and they said, we have no provision or no requirement to do indigent care in our state-supported medical schools. So you'll find a lot of those things will differ from one locality to another.
I'm in Virginia. We are stuck on that issue.
Are you using UVA?
We can't get past that on the contract. We cannot get an agreement as to what do you do with uninsured patients. I've been working at this for a year and a half.
Yeah. Well, yeah, we're fortunate, like I say, and they've been very accommodating for what we've done with them. And these other two questions down here, the one below that, talks about Virginia and the barriers to care. And Jeff brought this up earlier, and it's actually in the Congressional Federal Register, and it lists it's volume 79, number 91. It's on May the 12th, 2014, in Rules and Regulations. And they define the distance site as the site which the physician or practitioner is located at the time the service is provided via telecommunications. Now, their opinion that, again, denies us the ability to be a distant site under that says, since the definition of physician nor the definition of practitioner includes RHCs or FQHCs, we do not believe the statute is to be a distant site provider of these telehealth services. So again, it's just a definition that they don't recognize us as being physicians or providers, although our FQHC status identifies us as a Medicare provider. It's a provider status. So again, truly it's something that I would have thought would have been easy to overcome, but it is not. It's been a challenge to try to get that overturned. And just to speak for Virginia too, is Virginia has the parity law, which means that whatever service we deliver via telemedicine has an equivalent compensation and the same things as a face-to-face visit. Virginia's been very progressive at making certain that, Medicaid, commercial carriers, anybody that provides any state employee benefits or in state employee plans have to reimburse you in Virginia. So we're getting reimbursed for most everything except Medicare. We cannot get reimbursed for Medicare. But, you know, and again, you'll see that's probably going to be different from one state to the other. So anything else from you guys? I know Serene and them talked about, you know, when we first started, I've been doing telemedicine for about 18 or 19 years now. And when we first started, we were doing the incident to billing so that the specialists got paid on their end. We got paid on our end because we used at least a nurse practitioner or somebody to do the consult on our end, which really you're doing the examination. And it's an interactive consult. But in about 2004, 2005, CMS just footnoted that particular CPT code and said, we no longer recognize this through CMS. So, I mean, it's still a valid code. They just wouldn't recognize it on their end. So that stopped that process. But, you know, and then it became just that originating site fee, which originating site fee was only intended to pay for the equipment and the communication lines and that type thing. It was never intended to be payment for services on that end. And it started out as a flat $20. It's increased by about 3.5% by the Medicare cost index each year. So now it's probably about $28 or so. You know, you can't take, you know, 45 minutes or an hour's worth of time to spend with a patient for, you know, for that amount of money. So anything else from the panel on that issue or that side? Comments?
For North Carolina, we're in the dark ages in telemedicine, but we just went to managed care. So that will drive what'll happen. I'm confident because they want to do, the managed care will want to do some telemedicine, and they've already expressed that. So I think that, and they've already, I'm on a panel that they already are having those conversations. So I think by this time next year, we'll have some level of parity. But it was driven by the market because we've been presenting case on case on case, and they have funded us as 67 different pilots on telemedicine. So it's going to be driven by the market for us.
All right. And one thing we did not have a chance to get over was these state ATA, the American Telehealth Alliance or Association, their guidelines. But they're supposed to be included in the handouts on your on the app. So I would encourage you to go and pull those and look for those. I think we had the states that are in the Mid-Atlantic telehealth region. Plus, I think we added New York and Tennessee because you guys weren't in that area. But again, it's pretty good information to know pretty much where your state stands on some of those issues. And but like I say, these things are changing all the time, and I would encourage you to stay up on whatever current rules and regulations. Be proactive as legislation comes to your state about affecting reimbursement or affecting what they'll cover. Virginia, I know this year tried to push some things about the licensing across state lines and got defeated primarily by our state medical society. But they've vowed to come back and look at it again next year. So anything from the other states? All right. Well, and I'm not sure, is the survey in the app? If you guys can, for this session or whatever, complete the survey. If you got general questions, we'd be glad to take any general questions that the group may have too.
What state are you from? What state are you from?
Oh, there's none of it's covered. None of it is covered. So the originating fee is the only thing that's covered as an FQHC in North Carolina.
And
Just the originating site?
Right.
Is
Yeah.
it a Q code?
it is a Q code, right?
I don't know it off the top of my head. Center for Connected
Q40.
Center for Connected Health Policy is a good resource. That can give you a very detailed layout of what's available.
Yeah, and again, based on the states in Virginia, we would be able to bill Medicare, most commercial insurances, and probably be paid for those. But for Medicare, we would not. It would only be that originating site fee that we could actually bill for, which again is about $28. So.
Yeah, it's the same in Tennessee. We would be able to bill our Medicaid program, most commercial insurances, but Medicare would not cover that.
Anything else? All right. Well, you guys have been great, and we appreciate you coming to the session. Hopefully it's been somewhat informative for you, and we look forward to having you come back next time and talk to us about the opportunity of what you're doing in telemedicine. So thank you.